today's speakers are Dr. Ryu from Mayo Clinic at Rochester and Dr. Hilary DuBrock, also from Mayo Clinic at Rochester, and we'll share more information about them in just a moment. So as you know, this meeting is for informational purposes only. So before making any changes or, as you listen to the talks, you might learn things that you might want to speak with your medical team about, just because everyone has a unique and specific circumstance. We will save time at the end. We encourage you throughout today's talk to please put questions in to the Q&A, and we'll show you how to do that in just a moment. Then we will save time at the end to go through those questions, but we may not be able to answer all of the questions in this talk. So anything that doesn't get responded to, we will follow up with additional information. You can also always email your hosts, and we will provide follow-up as well. And we are recording the webinar, and we'll send that out as soon as possible if you'd like to share with any family and friends or to watch it again in the future. And today's talk is hosted in partnership between the Histiocytosis Association, the OR Association in Barcelona, Spain, and the Histiocytosis Association of Canada. My name is Diana Fournier. I'm the Executive Director of the Histiocytosis Association, and I'd like to introduce you to Fernando and Claudio as well. Fernando?
Hello, Diane. Thank you very much. And thank you all for attending to this webinar, especially Dr. Ryu and Dr. DuBrock. Thank you very much for your time and your efforts to really get into this such important issue. We have a lot of patients in Spain affected by pulmonary LCH. So this talk really talks to them, and it's something that's really super needed. Also for patients and for professionals to get much more knowledge on the pulmonary LCH. So thank you very much. And I will also will be answering questions in Spanish if needed, if some of the participants are Spanish as well. So thank you.
I want to echo Fernando's comments and thanking the staff and Deanna for putting this on. Looking forward to this conversation. There are many patients here in Canada suffering through this, and anything we can do to evangelize some of the support that's offered in the US and some of the advancements made globally is going to be benefit to our families. So thank you for that.
And thank you to both Fernando, Claudio, and your organizations for the incredible work you do and for your partnership, partnering together for the benefit of the Histio community around the world. So without further ado, I am excited to introduce to you today Dr. Ryu and Dr. Hilary DuBrock. Dr. Ryu is the Dr. David E. and Betty E. Dines Professor of Pulmonary and Critical Care Medicine at Mayo Clinic, Rochester, Minnesota. He attained his medical degree from the Johns Hopkins University School of Medicine. His internal medicine and pulmonary and critical care medicine training were completed at Mayo Clinic and Massachusetts General Hospital, respectively. He has been on the faculty at Mayo Clinic College of Medicine and Science since 1984. And his research interests include interstitial lung disease and rare disorders affecting the lung. Dr. Hilary DuBrock received her medical degree from University of Massachusetts Medical School, completed internal medicine residency and chief residency at Beth Israel Deaconess Medical Center in Boston, Massachusetts, and completed pulmonary and critical care training in the Harvard Combined Fellowship Program. She also obtained the master's degree and medical science degree from Harvard Medical School in the field of clinical and translational investigation. Dr. DuBrock joined the faculty at Mayo Clinic in Rochester, Minnesota in 2016 and is currently an associate professor of medicine. Her clinical and research interests include pulmonary hypertension, pulmonary vascular complications of liver, lung, and kidney disease. The goal of her research is to improve care and quality of life for patients with pulmonary hypertension. We are really thankful and grateful to both for taking time to host this webinar today, and I'm just going to turn it over to them and looking forward to everything that you're going to share with us. Thank you.
Well, thank you for that, Diana, Fernando, Claudio. We're pleased to be with you to discuss this topic. I suppose we should say good morning, good evening, good afternoon, wherever you are, and thank you for joining us. So today we're going to talk about this topic of pulmonary hypertension in Langerhans histiocytosis diagnosis and management. I'll start off by just laying the background, because I think sometimes terms can get confusing, and particularly in regard to pulmonary Langerhans histiocytosis versus Langerhans histiocytosis can be confusing. So I'm just going to try to clarify the background as best I can in that regard and share with you what we see as lung specialists in the lung when it occurs in patients with Langerhans histiocytosis. show you some cases of specifically pulmonary Langerhans histiocytosis and the complications that can occur with that disorder, and specifically pulmonary hypertension, which is what Dr. DuBrock will discuss in the second half of this talk. So let's move on. I have nothing to disclose. So we'll basically talk about the general aspects and then focus on pulmonary Langerhans histiocytosis, and then we'll focus on pulmonary hypertension diagnosis and management thereof. So, currently there are two different classification schemes in regard to these histiocytic disorders. So we have the Histiocyte Society classification and the WHO classification of histiocytic disorders. I think most of us favor the Histiocyte Society classification of histiocytic disorders. And among those entities included therein, Langerhans histiocytosis, along with Rosai-Dorfman and Erdheim-Chester disease would be the dominant entities within this category. To talk specifically about Langerhans histiocytosis, I think most of you know that we're talking about a histiocytic disorder that is characterized by neoplastic Langerhans cells of myeloid origin, that is to say, of bone marrow origin. And Langerhans cell histiocytosis is the most common neoplastic histiocytic disorder. And majority of patients who have Langerhans cell histiocytosis will manifest some variant or mutation of moieties or mediators in the so-called MAP kinase pathway. Now, this MAP kinase pathway contains various mediators and molecules that control cell growth and survival, such that if a variant of mutation occurs in the mediators along this pathway, there can be abnormal growth and survival of affected cells. And among these variants or mutations, the so-called BRAF V600E mutation is the most common one that's found in patients with Langerhans cell histiocytosis. And in regard to the epidemiology of Langerhans cell histiocytosis, currently it is estimated that about 1 to 2 per 100,000 in the general population have some form of Langerhans cell histiocytosis, more commonly in children than in adults. And in terms of organs involved, most commonly bones and skin, but certainly other organs can be involved, such as liver, spleen, lungs, which is what we're talking about today, and central nervous system, pituitary gland, and less commonly affected organs. When we see it in the multi-system form, meaning multiple organ systems are involved with Langerhans histiocytosis, that is seen more commonly in children, whereas single system involvement is more commonly seen in adults. So that's where the lung involvement with Langerhans histiocytosis belongs. Specifically, when we talk about so-called pulmonary Langerhans histiocytosis, we're talking about a form of Langerhans histiocytosis that involves the lungs in an isolated manner, meaning other non-pulmonary organs are not affected. And interestingly, that this pulmonary Langerhans histiocytosis is seen almost exclusively in patients who have been exposed to smoking. So we're talking about active smokers and ex-smokers. In fact, pulmonary Langerhans histiocytosis, about 95% of adults who manifest this disorder will have a smoking history. So then when we talk about so-called pulmonary Langerhans histiocytosis, we're talking about young adult smokers who may or may not be symptomatic at presentation, meaning sometimes we'll detect this disorder on chest imaging, whether it be chest X-ray or chest CT scan on an incidental basis. And this is a disorder that involves proliferation of these Langerhans cells, and I listed there for you some of the stains that pathologists will use to identify Langerhans cells or Langerhans cell infiltration in the lungs. And as we've said, it typically affects the MAP kinase pathway, with the mutation affecting that pathway that controls cell growth and survival. And in terms of what we see in the lungs, we'll see that the process of this Langerhans cell proliferation is accentuated around bronchioles, bronchioles meaning small airways. And it manifests sort of a nodular and cystic, sometimes combined nodular and cystic kind of changes as depicted on not only on lung pathology, on lung biopsy, but also on chest imaging, as I'll demonstrate for you in a moment. And what it does as this disease progresses is that there is decline in lung function, where the lung function becomes more and more impaired, particularly as patients continue to smoke. Sometimes we'll see pneumothorax or lung collapse occur because some patients will manifest cystic changes in the lungs that will predispose them to risk of air leak from the lungs, causing lung collapse. And I'll show you an example of that. And then, of course, what we're talking about today, pulmonary hypertension. And that Dr. DuBrock will get into in much more detail. So in pulmonary function testing, what we see are sometimes obstructed, meaning that there's airflow obstruction, where the air comes out slower on pulmonary function testing. Or sometimes we'll see a mixed kind of pattern of airflow obstruction and restrictive kind of impairment. Restrictive meaning lungs are acting like they're smaller than they should be. And very commonly, we'll see that the diffusing capacity is decreased on pulmonary function testing. Diffusing capacity measures how well the lungs are working overall in terms of gas exchange. And obviously, when lung tissue is affected, that diffusing capacity will gradually go down. And on CT scan, we'll often see irregular cysts. And interestingly, with this pulmonary Langerhans cell histiocytosis, we'll see that the lung bases, or the lower parts of the lungs, are spared, meaning they're not as affected as the upper and mid lungs. And I'll demonstrate that for you as well in a moment. And we often see nodules, sometimes nodules that are cavitating, and cysts, as well as these reticulopacities, meaning scar-like linear densities in the lung. Now, management, first of all, is for smokers to stop smoking. And often that'll cause the disease to stabilize. And if the patients have a more aggressive form of disease, sometimes we'll use these BRAF inhibitors, particularly if they manifest these BRAF mutations. So there are BRAF inhibitors such as vemurafenib, but also some of the MEK inhibitors. That's the overall pathway that's affected by mutations in this pathway, including this cobimetinib and other more traditional cytotoxic chemotherapy kind of agents such as cladribine and cytarabine and methotrexate and so on. So the complications that we end up managing in patients who have active pulmonary Langerhans histiocytosis are pneumothorax as well as pulmonary hypertension. And then when patients have severe disease or progressive disease, we may need to consider lung transplantation for those who may be eligible. So here's an example of a patient who's a smoker, 38-year-old man with pulmonary Langerhans histiocytosis. And on these cross-sectional images, starting from the upper lung to the mid lung to the lower lungs, you'll see that there are many more tiny nodules in the lungs than they should be, as accounted for by lung vessels. So you have many tiny nodules in both lungs here. And you'll see as you come to the bottom part of the lung that there are not as many nodules. So this is what is referred to as so-called basilar sparing, meaning this process of pulmonary Langerhans histiocytosis appears predominantly to affect upper and mid lungs, as you see in these top images. So this is a more nodular, mainly nodular form of pulmonary Langerhans histiocytosis as depicted on CT scan. Now here's a 31-year-old woman who's a smoker who has more advanced form and mainly cystic kind of changes. And you see in the upper lungs that there are these empty cystic kinds of spaces. When we say cyst on chest CT, we mean that there's an empty airspace surrounded by a thin wall of tissue, as you see there. And you see that they're scattered throughout both lungs. And again, here in the lower lungs, you see the abnormalities are much less apparent. You have some cysts here, but certainly not as prominent as in the upper and mid lung zones. So here's a so-called coronal view, which shows you the views of the lungs from top to bottom. And again, you see that upper lungs are much more affected with these irregular appearing cysts compared to the lower lungs. So this is a more cystic or cavitary form of pulmonary Langerhans histiocytosis. Now, the patient that I showed you with diffuse small nodules had relatively mild abnormalities on pulmonary function testing, whereas this patient had severe airflow obstruction, severe impairment with decreased diffusing capacity. Now, here's a patient with pulmonary Langerhans histiocytosis who developed right lung collapse, right pneumothorax. And you see that there's empty airspace here in the right chest with those arrows pointing to the lung surface, the pleural surface. And you can see that the underlying lung is abnormal with small, tiny cystic spaces that are apparent in both lungs. Now, here's a patient who has the main topic of today, pulmonary hypertension with pulmonary Langerhans histiocytosis. Now, this patient on CT scan has numerous tiny cystic spaces throughout both lungs. And pulmonary function testing demonstrates low FVC, which is the total amount of air one blows out as measured on pulmonary function testing, and decreased FEV1, which is the amount of air you blow out in the first second. And the ratio is low, suggesting airflow obstruction. And you see that the diffusing capacity, which, as we said, measures how well the lung tissue works in terms of gas exchange, is out of proportion reduced compared to what we see with FEV1 and FVC. And that can be a clue as to the presence of pulmonary hypertension complicating this disease, meaning diffusing capacity is much more reduced than we would typically expect just from lung parenchymal process. And in fact, as we look at this soft tissue window, looking at the mediastinal structures more closely, so here's the aorta, and here's the main pulmonary artery arising out of the right ventricle. The diameter of these two vascular structures should be about the same in a normal patient. But you see that the main pulmonary artery diameter is larger than the aorta. And as we measure it, the main pulmonary artery measures about 38 millimeters and aorta measures 32 millimeters. So that again is suggestive of the presence of pulmonary hypertension, the main pulmonary artery being larger than the aorta on cross-sectional imaging such as this. And in fact, this patient went on to have echocardiography and estimated right ventricular systolic pressure was indeed elevated to 63 millimeters mercury. And as Dr. DuBrock will tell you later on, when the estimated right ventricular systolic pressure is greater than 40, that would suggest the presence of pulmonary hypertension. And in addition, this patient had right ventricular enlargement as well as right ventricular functional abnormality as assessed by echocardiography. So with that, I hope I provided the background as to what pulmonary Langerhans histiocytosis is and the complications that can occur. And then I'll hand it over to Dr. DuBrock to talk about the aspect of pulmonary hypertension specifically.
The focus of this part of the webinar will be really talking more about the pulmonary hypertension aspect associated with pulmonary Langerhans histiocytosis. I do have some disclosures. So I've done some consulting for some industry companies that make some pulmonary hypertension medications, including Janssen and Merck. And then we'll be briefly discussing off-label use of pharmaceuticals in the setting of PH associated with pulmonary Langerhans histiocytosis. And so for our learning objectives, I want to first start by defining pulmonary hypertension as well as its classification and treatment. We'll talk about the prevalence and impact of pulmonary hypertension in patients with PLCH, and then review the management of pulmonary hypertension associated with PLCH and the role of PH therapy. And so how does pulmonary hypertension typically present? People usually have symptoms of shortness of breath as the initial presenting symptom, which is pretty non-specific, particularly when you also have underlying lung disease. And so that often leads to delays in diagnosis. The symptom of shortness of breath with pulmonary hypertension is importantly typically exertional and also progressive. And so it's not something that kind of comes and goes. It usually just gets worse over time. People can also have signs of right heart failure when the right heart, because of the high pressure, starts to not pump well. And that includes things like swelling in the legs, or even things like passing out with exercise. On physical examination, people can have elevated jugular vein, indicative of high pressures on the right side of the heart, a murmur of tricuspid regurgitation, so the heart murmur, a loud P2, which is the component, the pulmonic component of the heart sounds, and then swelling as well. And it could be swelling in the belly or swelling in the legs. There are a lot of different signs on different tests that can provide clues to a diagnosis of pulmonary hypertension. And so when people have shortness of breath or underlying lung disease, they'll often have some of these tests, like a chest X-ray or a CT, imaging of the lungs that can show an enlarged pulmonary artery. On a chest X-ray, we can see that kind of enlargement of the pulmonary artery here. And then because of enlargement of the right side of the heart, the right ventricle, usually there's this airspace in the lateral view, but when the right side of the heart is enlarged, we lose that retrosternal airspace here, and that's just a sign of right heart enlargement. On EKG, so kind of a usual a test you might do for shortness of breath or chest pain, we'll also see signs of enlargement of the right side of the heart or right ventricular hypertrophy. And then on lung function tests, the main finding in pulmonary hypertension is a low diffusion capacity, which Dr. Ryu talked about, and that can be a sign of pulmonary hypertension. But really the main test that we get for screening is an echocardiogram. And so these are tests that we'll kind of do more routinely, lung function tests, EKG, chest X-ray, and then just symptoms and physical exam signs that might prompt you to consider getting an echocardiogram to look for pulmonary hypertension. And so in terms of pulmonary hypertension, this echocardiogram really should be considered a screening test that assesses the probability of having pulmonary hypertension. So it's not a diagnostic test, but it estimates that right ventricular systolic pressure. And it does that essentially by this equation, 4 times the tricuspid regurgitant velocity squared, plus the right atrial pressure, which they're estimating looking at a vein in the belly and kind of how distended it is. And so we have this table here, which helps us kind of think about what the probability of pulmonary hypertension is. And so when people have a tricuspid regurgitant velocity less than 2.8, which typically equates to about a right ventricular systolic pressure around 36 if your right atrial pressure is 5. So the RVSP or PASP that Dr. Ryu had mentioned, less than 36. If that's less than 36 and there's no other signs of pulmonary hypertension, like enlargement of the right side of the heart, flattening of the septum that divides the right and the left side of the heart, then it's a very low probability that the patient has pulmonary hypertension and they probably don't need additional workup. For people who have that pressure less than 36, but other findings suggestive of pulmonary hypertension, they're in this intermediate range. And then once that pressure is greater than 36 or 40, it's in this intermediate range. And then this is usually a pressure greater than 50 that we're thinking of as a high probability of pulmonary hypertension. It's important to note that the echo can be inaccurate, meaning it can vary by more than 10 millimeters of mercury, half of the time that we get an echo and compare it to the gold standard test, which is a right heart catheterization. But the echo is important because it tells us about the function of the right side of the heart. And so it's really considered a screening test, but also important for prognosis as well. And this is just kind of looking at some of the things that we're looking at with the echo. So this is the right side of the heart, and that's that right ventricular enlargement I mentioned. And that right side of the heart is so big that it's squishing this left side of the heart, so it's not filling adequately. Similarly, here you see the right atrium being dilated. That's the top chamber of the right side of the heart and the right ventricle, and it's kind of squishing that left side of the heart. And so this is a person who might, when they exercise or try to exert themselves, they might pass out because that left side of the heart's not getting enough blood flow and it's not getting to the rest of the body. But the echo tells us about probability, low probability, low pressure, probably don't need further workup for pulmonary hypertension, and then intermediate or high probability may want to consider further workup. And so how do we define pulmonary hypertension? The echo is just a screening test. And I mentioned that right heart catheterization is really mandatory for diagnosis as well as classification of pulmonary hypertension. So with a right heart catheterization, we typically go through the neck. You can also go through the wrist or the groin, and you go in through the veins in the neck and then measure the pressures in the right side of the heart. So if you can imagine the neck here, The catheter goes into usually the internal jugular vein, into the superior vena cava, which is the next large vein, and then into the right atrium, that's that top chamber of the right side of the heart, to the right ventricle, and then it measures the pressure in the pulmonary artery here, and that tells us whether a patient has pulmonary hypertension or not. So these are typically outpatient procedures. They're invasive testing, but you end up with just a Band-Aid at the end, so it's not like a big surgery or anything. The catheter just goes in that vein like a big IV, measures that pressure, and that tells us whether people have pulmonary hypertension. We define pH as a mean pulmonary artery pressure greater than 20. And so that mean pressure is actually only something that we can get with the catheterization. And that's different from the systolic pressure that we're measuring with the echo. We also look at the pressures on the left side of the heart. And to do that, we actually blow up a balloon here in the pulmonary artery. And what that does is it tells us about the pressure kind of beyond the pulmonary artery. And we think of that as the pulmonary capillary or pulmonary artery wedge pressure. And that kind of helps us figure out what the pulmonary hypertension might be due to. And so we think of pre-capillary pulmonary hypertension here as a problem with the pulmonary blood vessels or the lungs themselves, where there's narrowing of those pulmonary blood vessels. And then post-capillary pulmonary hypertension is a problem really with the left side of the heart, where the pressure is high here, and it's almost just causing like a blockage or obstruction. And so the pressure ends up being high in the pulmonary artery too. In addition to this kind of hemodynamic classification of pulmonary hypertension, we also classify pulmonary hypertension into 5 different clinical groups. And so this is the current most up-to-date pulmonary hypertension classification system. They are in the process of revising these, and actually the new classification will come out next month, the end of August. But we have 5 groups. So group 1 is pulmonary arterial hypertension, and I included just a few examples here. So about half of patients actually have idiopathic, meaning we don't know what the cause is of their pulmonary hypertension. We have heritable associated with specific mutations. These people usually have a family history where their parents also had pulmonary arterial hypertension, one of their parents. Pulmonary arterial hypertension associated with drugs and toxins, sometimes chemotherapies, things like methamphetamine. And then PAH associated with different diseases like connective tissue diseases like scleroderma, congenital heart disease, or portal hypertension. And there's a few other subsets here that are less common. And then group 2 is pulmonary hypertension from left heart disease. So those people have high wedge pressures or high pressures on the left side of the heart. And we really treat those by focusing on treatment of the left side of the heart. Pulmonary hypertension due to lung diseases or hypoxia includes things like COPD, ILD, people who have combined pulmonary fibrosis and emphysema, scarring in the lungs. And then there's hypoxia without lung disease and developmental lung disorders. Group 4 is pulmonary hypertension due to pulmonary artery obstruction, which is typically chronic thromboembolic pulmonary hypertension. So this is due to blood clots or blockages of that pulmonary artery. And then group 5 is where PLCH is classified, at pH in the setting of PLCH. And it's referred to as these unclear or multifactorial mechanisms. And it includes kind of a wide variety of things like sarcoid, bone marrow blood disorders, renal failure, complex congenital heart disease, and pulmonary Langerhans histiocytosis, neurofibromatosis. So a lot of kind of funny things, but we basically don't know what's causing it, or there's multifactorial mechanisms. And we really need more information about these, but they're rare conditions, and so we classify it as group 5. So these are the specific hemodynamic definitions. So when we're getting that catheterization, as I mentioned, we call it pulmonary hypertension if that mean pulmonary artery pressure is greater than 20. And then for pre-capillary pulmonary hypertension, we call it pre-capillary if the mean pulmonary artery pressure is elevated, that wedge pressure on the left side of the heart is normal, less than or equal to 15. And the resistance, which is the narrowing of the pulmonary arteries, is greater than 2 Wood units. Now, even if you have pre-capillary pulmonary hypertension, though, that doesn't tell you what your clinical classification is. You could have group 1, idiopathic, group 3, lung disease, group 4, CTEPH, chronic thromboembolic disease, or group 5. And so it helps you kind of rule out group 2, but otherwise it doesn't tell you, exactly what clinical classification a patient has. And so it's important because our clinical classification impacts what we do for treatment, but I think it's important to just talk about the overall goals of PH therapy, regardless of what's causing it. So regardless of the cause, we want to improve the numbers. We want the mean pulmonary artery pressure to be better, the resistance to be better. That's kind of one of the goals of our treatment. And then we want to make sure the heart's pumping well as well. We also want people to have fewer or less severe symptoms. We want to improve their quality of life and their exercise capacity, like their 6-minute walk distance. We ideally want to prevent clinical worsening, so things like hospitalization or death from pulmonary hypertension, and then we want to improve survival. And so, this would be kind of the goal for all of our PH therapy interventions. But the treatment, the specific treatment, depends a lot on the classification of pulmonary hypertension. And so this is just kind of a schematic redrawn from the European guidelines. But what we see is for group 1 pulmonary arterial hypertension, which is here, the treatment is really medical therapy, consideration of lung transplant in eligible patients. For group 2, it's really treating the left heart disease is the main focus of that. For group 3, and that's ILD or COPD, it's really, again, optimizing the treatment of the underlying lung disease. And then they've recently revised this, but inhaled treprostinil is a medication that's approved for PH associated with ILD, but there's no approved therapies for PH associated with COPD. So within group 3, there's also kind of a heterogeneous treatment approach. And of note, inhaled treprostinil, which we use for PH-ILD, actually recently failed a clinical trial where it had worse outcomes for patients with PH-COPD, so they stopped that study early. So we can't treat all group 3 patients the same. It's really, you have to focus on, what disease is that the medications have been studied in. For group 3, chronic thromboembolic pulmonary hypertension, they have these blood clots, and we go in and actually will remove them with surgery or with a balloon procedure to kind of break up that scar tissue and blood clots in the blood vessels. And then for group 5, where PLCH falls, they say optimize treatment of the underlying disease, which hopefully people have done already, and then potentially PAH drugs, and that we really need clinical trials as there's no approved therapies for group 5 pulmonary hypertension. This is just a summary slide of all of our current medications for group 1. So that's pulmonary arterial hypertension refers to group 1. And so I just want to show this because we have a lot of treatment options. And so we target the nitric oxide pathway with phosphodiesterase 5 inhibitors. This is sildenafil or Viagra, basically. Tadalafil, we have a new combination pill. Riociguat is a medication that targets soluble guanylate cyclase stimulators. These are all pills that are endothelin receptor antagonists. And then we have prostacyclin medications that are available orally, inhaled, IV, subcutaneously. And then we have a new medication that was approved in the United States in March 2024. Wow, it's been a long while. Yeah, it was in March, which is called sotatercept, which is a subcutaneous injection every 3 weeks. And so this is a kind of a novel medication that is interesting because it's supposed to also maybe reverse some of the pulmonary vascular remodeling. So not just dilate the blood vessels, but reverse some of the proliferative processes that drive the pulmonary hypertension. And so we have lots of options, as you can see, to treat group 1 pulmonary arterial hypertension. What about these other groups? And so in PH-ILD, I think is a good example of where we have learned a lot about how you can't just treat all patients with pulmonary hypertension the same. And so the PH therapies that we use have been studied in ILD and many times actually have had worse outcomes. So for example, in patients with ILD who had pulmonary hypertension who were treated with Riociguat, this was a study that was terminated early because there was increased death and hospitalizations. And similarly, ambrisentan in the setting of ILD was also terminated early due to increased hospitalizations, whereas bosentan didn't have any effect. And there was a subgroup analysis with sildenafil that showed some improvement in 6-minute walk distance among those who had RV dysfunction, so dysfunction of that right side of the heart. But I think we've learned a lot that we can't necessarily, treat all pulmonary hypertension the same with our pulmonary arterial hypertension therapies. And we need to be really cautious because patients could potentially have worse outcomes. Things were looking kind of grim in the world of interstitial lung disease and pulmonary hypertension until the INCREASE study was published in 2021. That was a multi-center, study across several countries. That was a 16-week randomized controlled trial of inhaled treprostinil. That's one of the prostacyclin medications. It's an inhaled medicine that's 4 times a day versus placebo, so an inactive study drug. And they looked at patients with precapillary pulmonary hypertension. So they had to have a mean PA pressure greater than 25. That was kind of our older definition of pulmonary hypertension. And a pulmonary vascular resistance greater than 3 Wood units, also kind of the older definition of pulmonary hypertension. And they included patients just with a mix of lung diseases, just to point out here. So idiopathic interstitial pneumonia, chronic hypersensitivity pneumonitis, combined pulmonary fibrosis and emphysema, connective tissue disease. There were not inclusion of patients with pulmonary Langerhans cell histiocytosis, since they're considered group 5. But what they found was that inhaled treprostinil was associated with an improvement in 6-minute walk distance by 31 meters. So not a dramatic improvement, but considered to be clinically significant. An improvement in NT-proBNP, which is a blood test that tells us about stress or strain on the right side of the heart, and a decrease in overall clinical worsening, things like hospitalizations and exacerbations for their lung disease, but no change in quality of life. And there were adverse effects like cough, headache, shortness of breath, and dizziness. And so the FDA approved inhaled treprostinil for the treatment of pulmonary hypertension associated with interstitial lung disease in 2021. And so that's a medication we've been using for ILD. But as I mentioned, there was a recent study, I don't have a slide here, but they looked at inhaled treprostinil in PH associated with COPD patients, and they actually had worse outcomes. And again, that trial was stopped early too, which means even within the field of lung disease, we can't treat all pulmonary hypertension the same. And so there also was some subgroup analyses of the INCREASE study that showed that the people that were more likely to benefit were really the ones that were sicker. So they had a lower 6-minute walk distance, a lower diffusion capacity, the groups of idiopathic interstitial pneumonia and connective tissue disease, and those with a higher pulmonary vascular resistance, as well as those who got to a higher dose of medication. And so the European guidelines were published in 2022 and really just focus on, again, in patients with any lung disease and suspected pulmonary hypertension, focusing on optimizing treatment of the underlying lung disease. And then in patients who have suspected severe pulmonary hypertension, an individual approach to treatment is recommended. And so what about PH and PLCH? Well, there's not a lot of data out there, but we know that pulmonary hypertension is common among patients with pulmonary Langerhans cell histiocytosis. In looking at patients with PLCH who were referred for lung transplant, it's as high as 92%. Obviously, those are people with more severe disease, but it's very common among people with advanced lung disease. And then of those referred for echo, which is also a biased population because they're people who you were worried about pulmonary hypertension in the first place, but it's common among those patients as well, close to 90%. What we know is that the pulmonary hypertension seems to be disproportionate to the lung disease severity. So it's not just people with advanced lung disease, but even those with mild lung disease can still develop pulmonary hypertension. And it may be diagnosed at the time of their PLCH diagnosis or later in the disease course. And then it is classified as group 5 because of these unclear or multifactorial mechanisms. And this is just showing an example where there's kind of thickening of this blood vessel. And you can see how that kind of narrows the lumen or the opening of the blood vessel. And then that leads to obstruction and increased pressure from that increased resistance. So you're trying to pump all this blood from the right side of the heart to the lungs to get oxygen, but there's this blockage or narrowing that leads to stress on the right side of the heart. And when we look at pathology, this is just kind of another example, but what studies have found is that there's variability in the degree of vascular involvement, and it seems to be different kind of across the lung too. And so this study has concluded that factors other than direct vascular obstruction, so obstruction of those blood vessels, as well as inflammation, seem to contribute to the disease, and that there's thickening of arteries, but also direct invasion of the blood vessels by the Langerhans cells. But even outside of the Langerhans cells, there's pulmonary hypertension and pulmonary vascular changes too. So that's kind of why it's classified as this group 5, because the pathology, doesn't really look like idiopathic pulmonary hypertension. It's very unique, and that's why it probably requires a unique approach to treatment as well. They also found some evidence of post-capillary involvement. So, not just the pulmonary arteries, but maybe the pulmonary veins and venules as well. And this is just showing, again, that thickening of the blood vessel that can lead to that obstruction. Whereas this blood vessel is thin, this is from a normal person here in this area. And so this is much thicker, as you can see, and that leads to that increased resistance within the pulmonary blood vessels. And so when should you consider pulmonary hypertension and pulmonary Langerhans cell histiocytosis? Well, that DLCO, which is kind of a marker of the interface between the alveoli, the air sacs, and the blood vessels, it declines in that DLCO can be a sign of pulmonary hypertension. Or people with signs and symptoms of PH or right heart failure, like when people start having things like swelling in the legs, ascites like fluid in the belly, or they're passing out, that can be a sign of pulmonary hypertension. Or when the shortness of breath seems disproportionate to someone's lung disease. The lungs don't look that bad, but they're really short of breath, can't do much, short of breath getting dressed or walking to the mailbox. And, that might be a sign of pulmonary hypertension as well. This is an algorithm that was proposed back in 2004, so quite a while ago, but I would say there's, not been, much in terms of updates related to this general approach. So in patients who have pulmonary Langerhans cell histiocytosis, if they're asymptomatic, normal lung function, probably just follow their lung function. And then in those who have worsening shortness of breath or a change in their lung function, particularly that DLCO, then consider getting an echo. For people who are symptomatic or have abnormal lung function tests at diagnosis, then consider getting an echo at diagnosis to look for pulmonary hypertension. And then for those who have a PASP greater than or equal to 40, that's kind of in that intermediate to high probability range for the echo of having pulmonary hypertension. Then consider further testing, like that right heart catheterization, to confirm the diagnosis. And to also assess the effect of vasodilators. So we do that with nitric oxide testing, where we give inhaled nitric oxide and we look to see how the pulmonary hypertension responds. And then for those who have a low probability echo, right ventricular systolic pressure or PA systolic pressure less than 40, they probably don't have pulmonary hypertension, and you could consider just kind of monitoring them. And this is just another summary, but I think the first thing is always suspecting of pulmonary hypertension as the cause of dyspnea in a patient with PLCH. That's the first step, is to think about it. And then you could consider screening. That echo we talked about is the kind of the most useful screening test we have. It's best to do that in a stable outpatient setting. So when someone's hospitalized and they have, they're hypoxic and sick and on a breathing machine or other things, the echo is going to look bad. And it's not necessarily reflective of pulmonary hypertension in a stable outpatient setting, which is when you want to be treating people. And so we usually recommend that that's done in a stable outpatient setting, looking at that diffusion capacity, and then that NT-proBNP, which is that blood test that tells us about stress or strain on the heart. And then if it's low probability of pulmonary hypertension, then consider other causes of the shortness of breath. But if it's high or intermediate probability, then consider further testing for pulmonary hypertension. So what about prognosis? So when people have pulmonary hypertension really on top of any disease, it's usually associated with a worse survival. In patients with PLCH, the hazard ratio, meaning the increased risk of death, is about 4 to 20 times, meaning our studies are pretty small, so we have really wide ranges for what we think is possible in terms of the studies that we have. And then there are features on the echo of pulmonary hypertension, like that pressure on the right side of the heart, that are associated with the worst prognosis. And that worst functional class, which is really, you have symptoms at rest or with minimal activity or moderate activity, is also associated with worse survival. So what about treatment? So we've talked about diagnosis, how common PH can be in pulmonary Langerhans cell histiocytosis. And then in terms of treatment, there's no approved therapies because we have very little data, but there are case reports which provide some insight into the fact that people can respond relatively long-term to pulmonary hypertension therapy. So this was a patient who was diagnosed in 2004. who they published this case report going through 2014, but I will tell you that I still see this patient. And so he's currently a patient of mine in 2024. And they were treated with diltiazem because they had this nitric oxide response, and they actually did pretty well with that. This is the pressure. And so the pressure was kind of creeping up, and then they started therapy and it came down. And then they added bosentan, which is one of those endothelin receptor antagonists, and sildenafil. And then they switched the sildenafil to tadalafil. And this patient had had a pretty good response to therapy, where that right ventricular systolic pressure on echo was about 100 and came down to the 40s, which is, that intermediate probability, kind of a pretty good range there. And a sustained response over time as well, which is important. In a larger study, that's just one patient. And so, and the caveat is that we tend to publish case reports of patients who do well and don't publish case reports of people who don't do well. And so there is bias related to what's in the literature. But this was a larger study of 29 patients who had PLCH and confirmed pulmonary hypertension by right heart catheterization. And these people had pretty advanced symptoms. So they were short of breath either at rest or with very minimal activity. And had a mean pulmonary artery pressure of 35 to 45, where we said greater than 20 was abnormal. And then they, in about half, 12 patients, ended up treating with pulmonary arterial hypertension therapy. And actually, all of those patients did well with improvement in their mean pulmonary artery pressure and that resistance without any worsening in oxygenation, which is always a concern when people have lung disease. And then the 1, 3, and 5-year survival was actually fairly good for all patients, 96, 92, and 73%, with a trend toward better survival among the patients who were treated, even though they had more severe pulmonary hypertension. And so what the conclusion was that safety and efficacy of these PAH therapies in patients with PLCH needs to be properly evaluated by prospective clinical trials. So we need better data, really randomized controlled trials where some people are getting drugs and some aren't, to better understand the effective therapy in these patients. And then I just kind of want to wrap up with thinking about the risks and benefits of off-label PH therapy. Hopefully I touched upon it a little bit with the ILD group, and that we were using a lot of these medications, but then when we actually went and did well-designed studies, we found that they were actually harmful in patients, and additionally in the PH-COPD population. And so the benefits is that maybe people will get better in terms of how they feel, their functional class. Maybe the numbers will get better, the right heart will get better. But the risks are there's side effects to many of the medications. Most of our medications are quite expensive. There's a risk for potentially worsening oxygenation and increased risk of disease progression, as we've seen in some of our clinical trials. And sometimes when we treat patients off-label, we limit their ability to participate in clinical trials and understand more about their pulmonary hypertension. And so what's my approach? I would say I have an individualized approach to each person, but I really first try with optimizing the lung disease as the mainstay of intervention, in that I optimize the oxygenation. So when the oxygen levels are low, it causes the blood vessels to constrict or narrow. That worsens pulmonary hypertension. So I try to make sure the oxygen levels are, hopefully in the low 90s, at least both at daytime and at nighttime. Optimizing the volume status with diuretics or fluid pills or water pills. So making sure people aren't retaining a lot of extra fluid that causes more stress on the heart. Pulmonary rehabilitation can improve a lot of things in pulmonary hypertension: quality of life, exercise capacity, even some studies that can improve function of the right side of the heart. So I usually refer patients for pulmonary rehab. Certainly lung transplant referral for eligible patients. So that's a cure for pulmonary hypertension. And then I do consider pulmonary arterial hypertension medications in an individualized approach, usually PDE5 inhibitors, inhaled or subcutaneous or IV prostacyclin medications, or calcium channel blockers in these vasoresponders, because some of them do seem to respond long-term to the calcium channel blocker therapies. Certainly engaging palliative care for assistance with symptom management can be helpful. And then if there is availability, enrollment in clinical trials, often there isn't because it's such a small subset of patients. But that's really the best way to really know, whether our interventions are effective. And so what can you do? I think as a patient, talking to your doctor about pulmonary hypertension and additional testing such as an echocardiogram, if you're experiencing signs or symptoms of pulmonary hypertension, As a clinician, considering echocardiogram to evaluate pulmonary hypertension in PLCH patients who are symptomatic, and then referring those with suspected PH to a pulmonary hypertension center. This is just a list here. I did a little screenshot of a map. So Pulmonary Hypertension Association is based in the United States, but there are also, European and various pulmonary hypertension patient foundation and associations similar to the Histiocytosis Foundation that has centers across the country with, less representation out here, but it's helpful to be evaluated at a pulmonary hypertension center of expertise if you're having difficulty with, getting your questions answered about pH or pH treatment, because these people are all accredited by a formal, testing and making sure that we're all kind of meeting the same criteria. And then as a foundation, I think considering advocacy for clinical trials, which would be ideal, but even just registries to collect data on the safety and efficacy of PAH therapy in pulmonary hypertension and pulmonary Langerhans histiocytosis, just to get more information about it. And so with that, I'll conclude that PH is common among patients with PLCH and can lead to symptoms of shortness of breath, swelling, passing out. A diagnosis of PH-PLCH requires you to think about it in the first place, that high index of suspicion, but has important prognostic and treatment implications. There are no approved therapies, but varied therapies have been used with good effect in small case series. And then referring patients with suspected PH to PH specialty centers for consideration of that invasive right heart catheterization for definitive diagnosis and considerations of treatment. And with that, I'll stop and we can take any questions.
Looks like there's one question. I think you partly answered this. Question is, why is PLCH in group 5 rather than group 1 with interstitial lung disease? Is it the multifactorial issue?
Correct. And so they actually just discussed this. The 7th World Symposium was just in Barcelona a week ago, and discussed the specific issue of, whether it should be in group 3. But given the pathology findings, they really felt like it was multifactorial and it didn't behave like ILD. It was very different. And so to kind of respect that multifactorial component and the pathology basis, it was put in, they kept it in group 5.
Yeah.
But that's a good question.
Kristen, Fernando, Claudio, questions?
Yes, hello. First I wanted to, while we await some additional questions, I do have one, but I wanted to thank both Dr. Ryu and Dr. DuBrock for being with us here today and for sharing their time and expertise with all of us. It was a fantastic presentation by both of you, so thank you very much. And again, I encourage questions if anyone has them. We have a couple minutes to answer those questions, but I did receive one from one of our community members that could not attend today. So I'm going to share that with you, and I think it's for you, Dr. DuBrock. Are there different parameters to determine pulmonary hypertension in a person with interstitial lung disease compared to idiopathic pulmonary artery hypertension? Or are pressures considered high by having a mean pulmonary artery pressure of more than 20 millimeters of mercury and a pulmonary vascular resistance of higher than 3 Wood units, regardless of any associated disease?
Excellent question. And so the definitions for pulmonary hypertension are the same regardless of the cause. And so it's that mean PA pressure greater than 20. And actually in 2022, we lowered the PVR threshold to greater than 2 Wood units. So from 3 to 2. And that was because there was some findings that people who had a PVR of 2 to 3 Wood units actually behaved more like pulmonary hypertension. And so that's kind of the definition, regardless of whether you're group 1, 2, 3, 4, or 5, with that precapillary pulmonary hypertension being either group 1, 3, 4, or 5, but not group 2. And then the caveat to changing the definition of pulmonary hypertension is that even with treatment, like of group 1 pulmonary hypertension, our medications have all been approved for people who had the older definition of pulmonary hypertension, which was a mean PA pressure of 25 or above and a PVR of greater than 3. And so we're kind of left with this group of people with, mild PH, mean PA pressure 20 to 25 or PVR 2 to 3, where we don't know if our medications work because they haven't been studied. And we're we're kind of left with an open question of what we should do with those patients. But our medications that we have, all of that, the big table of PH therapies I listed, were all approved for the mean pay pressure 25 and above, or PVR of 3 Wood units.
Dr. DuBrock, if I may ask, maybe something related to what you mentioned about the registries of patients, and also something about the inhibitors. Regarding to the registries, you mean that there is no something specific for pulmonary LCH? Means that the pulmonary patients or the doctors, the treatment doctors, should look at their own registries, but there is nothing global going around for adult patients or
not that I know of. You know, we've learned a lot about pulmonary hypertension from different multi-center registries, often sponsored by industry, that have given us a lot of insight into, you know, long-term outcomes, treatment efficacy in kind of a real-world setting. There aren't any registries that I know of, but sometimes with these rare diseases, that's really, I think, what needs to be done in order to better understand the outcomes. Otherwise, you just have kind of small centers of expertise reporting their experiences, but you're not getting the larger picture. So that was just kind of a thought I had. I don't have any.
No, because I understood that Dr. Diego Castillo in Spain is running kind of a registry as well, and I thought
that's great.
Yeah, so I thought but it may be related to European patients only, or Spanish patients.
Yeah, but even understanding then, you know, when people are treated, recording the outcomes of that too. You know, are they having follow-up echoes and cath
and also related to inhibitors? Or you mentioned something about that there is nothing approved, especially for PLCH. But if I understand correctly, there might be a use of MEK inhibitors for some cases, for some aggressive cases of PLCH for adult patients. It can be thought of as a treatment, as a possible treatment.
The treatments for pulmonary arterial hypertension.
Yeah.
And so those are ones that I think that's that individualized approach where we might consider using PAH therapies. And I have several patients who have been on the treatments for group 1 who have PLCH and have done well with it. And so that's where I think that's where you need to be seen at a PH center of expertise to deal with the risks and benefits and have a discussion with patients about, you know, whether it's a good idea to start these medications. And it depends on the disease severity. Certainly with mild pulmonary hypertension, I probably wouldn't, but in those people who have more significant PH, I would consider it, but then follow patients closely to look for some of those side effects. And it's often difficult to get it approved from insurance. So that's usually an issue that we encounter. And there's 2 ways to approach that, which I won't advocate for one or the other, but one way is including the papers to the insurance company that have looked at outcomes of PAH therapy and saying, you know, we're using this in the setting of pulmonary Langerhans cell histiocytosis, but justifying it on the basis of these prior studies that have showed benefit. Or sometimes we end up just calling it idiopathic pulmonary arterial hypertension, saying it's idiopathic. We don't know what causes it, but then potentially getting it approved that way. But it's, you know, you're saying it's disproportionate to the underlying lung disease, and so maybe something else is driving it. In terms of pulmonary hypertension, and associated with like mitral valve prolapse and mitral valve disease, really, it's just looking at the echocardiogram to look to see if it's pulmonary hypertension, pressures on the right side of the heart, or whether there's issues with the left side of the heart and the leaky valve that could be causing some of those symptoms. But the ultrasound of the heart is probably done on a relatively regular basis in the setting of the mitral valve prolapse, but that would just be the way to know.
There are 2 additional questions. The first one is, my normal blood pressure runs on the lower side, and I've tried 3 different meds that have had side effects that were unmanageable. Are there any therapies, meds that will not lower my overall blood pressure?
Is that pulmonary hypertension medications? I assume.
That's what I would guess, Hillary.
Okay. So It depends. So the inhaled pulmonary hypertension medications tend to have less blood pressure effect than the pills. Also, we will sometimes use midodrine, which is a medication that can help to increase the blood pressure in order to get people to tolerate their pulmonary hypertension medications, because they do dilate the blood vessels. The midodrine, it can constrict the blood vessels, so it kind of helps to manage the blood pressure without causing problems with the lung blood vessels. And so that's kind of typically what our approach would be. But it sometimes it's a trial and error of just trying different medications to see which has the most blood pressure effect, or trying a lower dose of medications and things like that. And then the other question is more related to the chemotherapy medications, which would not be related to the pulmonary hypertension. So not something I don't think I can address. But the heart stress test is really looking for, problems with the heart and what happens to the heart under stress, looking at things like blockages or pressures and things like that. And that's a pretty routine test that we'll do in people with shortness of breath or chest pain.
For more information specifically on Histiocytosis Association, you can go to histio.org or scan the QR code with your phone if you're watching from a laptop. And there's also community forums you can get involved with on Facebook at on the address right there on the screen.
Well, about the information from our association in terms of adult patients with what we are talking about today, we have some special adult groups. It's for emotional support, especially, and this is typically also for this type of let's say the different histiocytosis, and we have learned today about this the pulmonary side, and this is something that really worries the patients, and I encourage the patients everywhere to get in contact with us to try to participate in these groups, because there is where you can also ask your peers and ask for more information, try to get involved. And also important that we have everything in the YouTube channel, in our YouTube channel of our association. You have this type of talks, of many different talks also that are related to adult patients and to pediatric patients. Thank you.
Thank you for that. The panel was fantastic. Great questions today. So thank you for all your time and efforts today. For anyone in Canada or wishing to look at some of the opportunities that we bring to our patients and our families, please follow the link below, and our QR code will send you directly to that site. So again, thank you to everyone, and thanks to the HA for putting this on.
Thank you so much to all.
Okay, thank you.
Thank you.
Have a great day, everybody.